Okay. So obviously this is just an introduction to the Mental Health Act, and knowing that you're kind of in this year, you can actually implement certain sections of this yourself. So we can talk about that in a little bit more detail a little bit later. But this is just a rough introduction, so that you know roughly kind of what powers you have, if any, how to deal with kind of people that you may have concerns about, generally kind of their mental health and well-being, and how to keep people safe as well. So we'll obviously just very briefly explain the differences between the Mental Health Act, Mental Capacity Act and DOLS, just kind of how they work together and what the differences are. And then we'll just briefly cover some of the commonly used sections that may crop up in general hospitals. And then I'll go through a little bit about the assessment process. If you aren't familiar with it, there's obviously there's a process that needs to happen in order to detain somebody lawfully in certain sections, so we'll go through that. And then the 136 police power, which you may or may not have heard of, this is quite common in A&E, so I'll go through that in a little bit more detail. The 5.2 holding power, which obviously you can use now if you ever have concerns. And then the last kind of 4 bullet points there is just things that you won't necessarily be involved in making decisions about, but it's just so that you're aware of those sections and how they can crop up in your hospitals, and how you may be dealing with somebody who might be subject to either any of those circumstances. I think this clicker is, there we go. So obviously we've got 3 kind of pieces of legislation that comes across and is used in general hospitals, and that's the Mental Health Act, the Mental Capacity Act, and the Declaration of Liberty Safeguards. And these are all slightly different. Some of them will interlink, well, all of them will interlink actually, but you've got the Mental Health Act, which is what we're going to focus on today, and this is to primarily treat somebody for a mental disorder who is not consenting or not complying. So this isn't to override consent, basically. It's used on any patient of any age, so they obviously have to meet certain criteria depending on which section is being considered, but it can be used from anybody. Cradle to grave is what we kind of refer to. So there's no age limits for the Mental Health Act. If you have concerns and there is criteria met, then anybody, regardless of capacity as well, can be sectioned or detained or subject to the Mental Health Act. The Mental Capacity Act, this one, obviously, there is slightly more limits to this one. So the Mental Capacity Act can be used to make decisions for those people that lack capacity to make those decisions themselves. So this is a big piece of legislation. It is separate to the Mental Health Act. It has its own act, its own manual, its own code of practice, its own guidelines, but they do work together. So the principles of the Mental Capacity Act are always used with those who are subject to the Mental Health Act as well. So they do cross over quite a lot. And then you have the Declaration of Liberty Safeguards. So this is part of the Mental Capacity Act itself, but it does have its own code of practice because there are lots and lots of considerations and lots of safeguards that need to be taken into account in order to protect these people and treat them correctly. But this is, again, for those over the age of 16, so because it's the Capacity Act, it can only be used on those over 16 and those who lack capacity. And this is to deprive a person of their liberty. So this authorises people to be deprived of their liberty. Usually when people are really, that you need like really restrictive care plans in place, they can't leave where they are, they need constant supervision and monitoring, and potentially, they could be very, very vulnerable as well. So they're kind of the differences in those 3 pieces of legislation, and we will park the Mental Capacity Act and DOLS at the door for now, and we'll focus on the Mental Health Act. So these are the common sections that you may come across in a general hospital. So you can see you've got kind of 2 longer term sections there, your section 2 and 3, and then you've got your 5.2 and 136, which are very short term sections, and these are primarily for the purpose of keeping someone somewhere in order to assess and then potentially there could be a further outcome of longer detentions and another subject of the Mental Health Act. But just to kind of explain, so the 5-2, which this is could be put in place for up to 72 hours, and this is primarily just to keep someone in a safe place for further assessments. And you can see that this does not allow treatment for a mental disorder to be forced upon a patient, whereas if someone was subject to a Section 2, you could treat them using the Mental Health Act and the powers that you have available to you. And you can see the differences in appeals as well. So if someone is subject to certain sections of the Act, they can actually appeal their own section in order to potentially be discharged from that section. But you can see that that only applies to those under Section 2 or 3. So, obviously we've got lots of different ways that somebody could be detained or made subject to the Mental Health Act. And this will differ depending on their circumstances and depending on kind of where they end up or where they kind of start their journey. So the most common route is that the patients tend to be in the community. They may or may not be known to services or local mental health services in the area. But say, for this particular example, say this person is known to services and they may just voluntarily be taking their support. Potentially, they might be getting kind of regular follow-ups, regular visits, and that maybe the social worker goes and visits them one day and notices that actually we've got concerns that you may be starting to neglect yourself, you may have some kind of physical problems because you're neglecting yourself, you might have cut yourself one day and then not taken care of it, so actually it looks like it could be kind of slightly infected and you need to get that looked at. So the social worker may offer some support or offer some suggestions in order to kind of look after that person a little bit more. But potentially that person may be refusing all help. And most importantly, when it comes to the Mental Health Act, they are refusing help for their mental health needs. Physical healthcare needs, yeah, it does come into it, so it could be that actually, no, I don't want to go to hospital, I want to let this wound get infected, because of the neglect that they're experiencing. So actually, they could arrange a Mental Health Act assessment, because actually if someone is feeling like that, then potentially there could be concerns that something else might be wrong. So they could arrange an assessment, and then depending on obviously the physical needs, if there are any, or if they're significant, then they could be detained to a general hospital to get treated for their physical, any kind of physical needs that they have, but whilst also being detained to the act, under the Act. So that's kind of one way in which they could end up in a general hospital. Similarly, the same thing could happen, but they go to a psychiatric unit in the first instance instead. You've also got your 136. So this is a slightly shorter route, I suppose. And this is when people tend to be found or come across in the community, and police have concerns about a person, and they would take them to what we refer to as a place of safety. And I'll go into a little bit more about that in a minute. You've also got patients who are already in hospital. So again, very, very similar to the patients in the community. They may already be in hospital, a general hospital, for, I don't know, something like a broken leg, which has nothing to do with the patient's mental state or mental health or anything. But it might be that the fact that they're in hospital it might stress them out, it might trigger something. So actually they then start presenting in a certain way that actually means some people have concerns that there's something underlying here and we have concerns about your mental health. So actually we think you need to stay here. Potentially you might offer some suggestions, some help, and then again they have to be refusing that help. Or they could be in denial. They could, refuse all kind of supports and say, no, I don't have a mental health issue whatsoever and I want to leave this hospital right now because I don't want to be medicated. So again, in that instance, you can contact liaison services if you have any concerns about mental health or welfare of your patients, then you can get liaison involved, and they would generally often suggest that they need an assessment. So again, they can be assessed in that hospital, and then depending on their significant kind of physical health needs, they can either be kept at that hospital and further detained at that hospital, or they can be transferred to a psychiatric unit to focus on their mental health care. Now, this all ties into the power that's available to you in the time that you're waiting for assessments, because sometimes assessments don't happen straight away. So obviously you could be waiting a day or two, potentially, where the patient is, does start getting quite distressed and continuously says that they want to leave. So you do have a short-term holding power available to you in order to keep that person safe, whilst you can wait for this assessment for them to be able to look at what further support that they might need. Does anyone have any questions about that so far? No? Okay. There we go. So your 136 power. So obviously, has anyone come across the 136 when involved in any patients that might have been subject to it? You're nodding, yeah? Okay. So obviously this is a power that the police have. So this is only available to those police officers, and ultimately what could happen is that they could come across a patient in the community or some sort of public space, or they might have had calls from concerned kind of citizens or people in the community, and they, obviously police officers aren't trained or skilled in recognising the mental health kind of symptoms and behaviours and signs, but I think everyone could probably say, I have concerns here, your mental health, your mental state is not quite right. So police obviously start to recognise certain behaviours that could look like certain mental health disorders. So they will, if they believe that this person may be suffering from a mental disorder, and if they're in immediate need of care and control, then police can use this power to take these people to a place of safety. Now, a place of safety could be somewhere that's dedicated. So in Sussex Partnership, for instance, or any other mental health trust around the UK, there will be dedicated places of safety for each trust. So police will usually contact a liaison or kind of call, kind of point of contact for that trust and identify whether there is a place of safety available in order to take that person there to better support them. If all of these places of safety are full, then this person could be taken to A&E, or they may be taken to A&E straight away if they have significant health needs. So if they're in trouble, if they've injured themselves in some way and need medical attention, then they can be taken to A&E. The 136 is a very short-term holding power, so it can last for up to 24 hours. And this will start at the time this person arrives at A&E or the place of safety. It can be extended, so this would tend to be dependent on the circumstances of the patient themselves. It may be that they are in such a state that the assessment would not be appropriate to carry out. Then potentially a doctor would come along and decide, okay, we can't carry out an appropriate assessment. It wouldn't be in the patient's best interest to take this through now. So we're going to extend the 136 in order to keep them here so we can undertake this assessment fairly. And that could be extended for up to 12 hours. So overall it could be up to 36 hours. It used to be 72 in total, but they recently changed it. It was about 2 years ago they changed it. So it's a very shorter term now. Okay, so obviously ultimately police will detain someone on a 136, not just because they want to, but they will do it out of concern for that person. So they will take them to the appropriate place in order to better support them, and so that we can carry out an assessment to identify whether this person needs any further support. And this support could look like potential kind of, referring you to community services, or it could be, actually, we think you need time in hospital. Will you come with us and be a voluntary patient in a psychiatric unit? Or potentially it could be detention under the Act, depending on certain criteria. But obviously, ultimately, there are lots of different people that will be involved in this. And the first thing that would happen is that a doctor would come and assess, and ultimately that doctor would come and say, okay, yes, I recognise these behaviours and symptoms as a mental disorder. Not really sure which mental disorder yet, but they might have some idea. So then there will be a further assessment involving more people. But the doctor could come and say, actually, no, this isn't a mental disorder. I'm not concerned for your mental state. You've just drank too much. You need to go home and sleep it off. Potentially, it could be something like that. So depending on obviously what happens, if a person comes into somewhere like A&E on a 136, then they must be assessed. That is what needs to happen as the purpose of a 136. Because ultimately, we don't want to just bring people in and let them go without checking to see whether there's further support. This clicker's quite late. There we go. You can transfer between places of safety. So if someone comes into A&E on the 136, then potentially they might have spent 4 hours there being aided to. They might then be, medically fit to then go somewhere else. If they haven't yet been assessed in that time, then ultimately they need to be transferred to a place of safety within the relevant trust. So they will transfer that person if there's a place of safety available. Otherwise, they may end up in A&E until the assessment can take place. But you can do it the other way around as well. But it's important to remember that there's no change to that time limit. So if someone comes into A&E, they spend their 4 hours there and then gets transferred to the place of safety in the mental health trust, then that time limit will stay the same, including travel time. Same the other way around. Someone might injure themselves in a place of safety and then have to come to A&E. So if you're ever dealing with anyone who's subject to this section, then do just consider the time frame. Any questions about 136? No? Okay. So, the assessment process. Obviously, this has to happen for any patient anyone that's detained under section 2 or 3, or certain other sections of the Act, but we'll focus on 2 and 3 for now, has to have been assessed. And this assessment process involves kind of 3 people. 2 of these people are doctors, and they are there to provide medical recommendations. So they're there to look at all the kind of clinical reasons as to why somebody should or should not be detained under the Act. One of these doctors should be Section 12 approved, and this just means that they have the experience and skills in recognising and treating mental disorders. And ideally, one of these people should know the patient. So often, we would go to a person's GP and ask them to do a recommendation. However, sometimes they're not available, so ultimately it could be anybody that's available in order to assess this person. This is a preference. If somebody is assessed by 2 people that don't know them or don't have prior acquaintance, then they have to just explain why. It could be out of hours. A lot of these assessments take place out of hours and there's no one available that know the patient. Both of these doctors have to identify if they believe a mental disorder to be present. So if it's a Section 2, they don't necessarily have to diagnose them there and then straight away. They have to establish whether actually, yes, we recognise these signs and behaviours and the way these people are presenting to reflect what we see in other mental disordered patients. So they can just say, yes, we think this is a mental disorder. We think there is something more here, or not. And they have to establish whether there is a risk to that patient or other people because of that mental disorder. So that is their purpose, the purpose of those 2 doctors. And we get 2, so that there's no kind of conflict of interest, and there's 2 recommendations there. Those 2 doctors could disagree. One of them could say that, yes, there's a risk to this patient, but not others. And the other doctor could say, yes, there's a risk to others, but not the patient. But as long as both of those 2 doctors agree that there's a mental disorder, and then the third person, who's an AMP, comes along and agrees with both of the doctors and says, yes, we established that there's a mental disorder, this person is not agreeing to come into hospital voluntarily and they're refusing treatment or admission, and there's nothing else we can do, this is the least restrictive option, then that person could be detained. So the AMP, who's an approved mental health professional, has the final say in all of these assessments. So they come along and they will discuss it with the doctors, and they will either say, yes, I agree with you, we're going to carry on detaining this person and I'm going to make an application to hospital, or they will say, no, I don't agree that this person needs admission, let's look at community support, let's look at some other options. There we go. So an AMP could be, usually is a social worker, but they could be other kind of different professions, qualified nurses, occupational therapists, anybody who has that additional training. And an AMP should always be accredited to undertake that role, usually by the relevant local authority that they work for. So they will look at alternatives. So as I said before, they will have a look to see whether actually is detention, the right way. Is this the right thing for the patient? Are we doing what's in the best interest for them? Or is there another way we can do this which doesn't take their freedom and restrict them so much? And they have to identify and seek the views of a person's nearest relative. So under the Mental Health Act, certain people detained under certain sections will have a nearest relative, and this person is usually kind of a mother or father or sister, whoever. There's a list of who it should be, and they will act kind of like a support for the patient, and they have a dedicated role within that patient's detention. So it's slightly different to a next of kin, which you would probably see generally. Next of kin people can choose, but nearest relatives people can't. It's identified for them and they're basically told, this is your nearest relative, can we contact them? This is what their role is, do you agree for us to talk to them? Whereas a next of kin, it's like, who would you like us to talk to? So they are two different roles. So if you ever do come across that, don't get them confused. Once an application has been made by this person, made by the AMP, they have the power to convey that person to the relevant hospital. So it's not just a case of, okay, let's get in my car and I'll take you where you need to go. They often delegate this role to other people who has better facilities to be able to support that transfer in a better way. So often kind of police may do it, secure transport or ambulances. They might take the person, might be more appropriate to take the person to whichever hospital they're being admitted to. Of course, if they're staying where they are, then we don't necessarily need this power, but it's there. Any questions about the assessment process for now? No? Okay. So Section 2 or Section 3. Now, obviously, it's not your responsibility to identify which one we're going to look at. This is the responsibility of the assessing team to consider which section is more appropriate. So you can see there, this table just outlines the criteria as to, okay, this person meets all the criteria for Section 2, let's detain them under Section 2. Or vice versa, this person meets the criteria for Section 3. And you can see that some of them are very, very similar, and some of them do have differences. So your Section 3, there is more criteria to meet, and this is because Section 3 is that much more restrictive and so much longer. The biggest difference, if you are ever curious as to why someone was on a Section 2 rather than a Section 3 or vice versa, Section 2 tends to be used when patients might not be known to services, they may never have presented with mental health issues before, and it might be that no one knows what the true cause of this is, so actually more investigation needs to happen. So they would tend to use Section 2 on those kind of patients, whereas Section 3 tends to be used for those that have a long history, they have an established diagnosis, and actually they just need a period of time in hospital for treatment for that mental disorder. So generally speaking, they're the main differences if you're ever wondering. Okay, so medical treatment. When we talk about medical treatment for a mental disorder, the Mental Health Act describes it as anything to prevent a worsening of the mental disorder or one or more of its symptoms or manifestations. So you can see there that it doesn't just include your general medicines, it can include your nursing care, psychological interventions, any therapies, anything that's going to improve that person's mental health and help stabilise it. So a bit more on medical treatment. So we've got medical treatment only applies to certain sections of the Act. So if you remember the table before, you couldn't force treatment on someone who was on a 5.2, but you could for someone on a Section 2. So this is where this all kind of fits in. So Section 2 and 3, this medical treatment section, part of the Act, applies to those patients. And that section means that we can treat the mental disorder, but it has to be given under the direction of a person's responsible clinician. This clinician, would be responsible for assessing that person's capacity to decide whether they have capacity to consent to the treatment or not. So obviously they would be the lead doctor in deciding that whether actually they have capacity and they're consenting, or they have capacity and they're not consenting, or vice versa, they actually lack capacity, so we need to look at something else. And medical treatment under the Act can include any ancillary treatment for mental disorders. So this can include blood tests to monitor any clozapine levels, and it does include NG tubes, where possible, to potentially treat eating disorders. To demonstrate it's people with kind of personality disorders, the example there is that they went on hunger strike. So the responsible clinician established that, okay, this hunger strike is a manifestation of this person's personality disorder. Potentially, if they didn't have this personality disorder, they wouldn't be going on hunger strike. So it is linked and related to that person's mental disorder. So because of that, then medical treatment and potentially force feeding that patient was all authorised under the Act, specifically Section 63. But you don't need to worry about that particular section. So we have a few scenarios here. Patient was admitted to an acute hospital and they had a mental disorder and they were detained under Section 2, so they already detained. They were bloodletting and needed transfusions, and at times this patient was actually resisting. So we have a few options. Ultimately, we always want to treat with consent, so just because a person is detained under the Act doesn't mean we can just do whatever we like. You know, we have to always give them that option. We have to give them the chance to consent. So great, if they do, perfect, we can treat you. Obviously, at times this person doesn't want, so he's clearly not consenting. So in this circumstance, the responsible clinician would need to establish whether the bloodletting was actually a symptom of this person's mental disorder and whether it's related to it. So if they have established that, yes, I think this is related to this person's mental disorder, then you can use the powers of the Act, because that person is detained under Section 2, in order to treat that person. If they establish that, no, this is nothing to do with the person's mental disorder, then of course you don't have those powers of the Act available to you, because it's not linked. So you would have to assess a person's capacity, and if they lack capacity, then you'd have the options of the Mental Capacity Act available to you in order to treat that person in their best interests. If, of course, it's not a symptom and actually the person has capacity and just doesn't consent, then ultimately we can't really do anything. You know, we shouldn't treat that person, unless, of course, you have concerns that actually inherent jurisdiction might apply. So obviously, if you have concerns that this person is vulnerable and their choice to not have this treatment is going to put them in danger, then there is something you could do. But if that was the case, I would suggest you talk to kind of senior members of the team and potentially legal services about that, because they can support and make sure that everything's done lawfully. Ultimately, this just emphasises the point that if somebody is detained under the Act, then you can treat the symptoms or kind of anything that's related to the mental disorder. If somebody has a physical need that isn't related to the patient's mental disorder, then you can't use the Act. So the fact that they're detained is irrelevant. You would still have to get consent, or of course use the Mental Capacity Act, if that's an option. Any questions about that?
There's a patient like this, I think, comes in around Eastbourne.
Yep.
That I saw maybe a year or two ago. And he had capacity. He had not, obviously not reasons you probably agree with, but he had fairly sound reasoning for why he was bloodletting.
Yeah.
And didn't want transfusions because he said, "You're giving me a transfusion, I'm going to go home and take it back out again."
Mm-hmm.
Wasn't under reception. And if he's got capacity and he can refuse treatment and there's nothing else he's in hospital for, I mean, at the time I don't think we could put him under reception 5-2. It was like a stable chronic condition. He'd been doing it for absolutely years, nothing had changed. And he had, full capacity, understood what he was doing and had his own reasons for doing it that were not, not psychotic or anything.
Okay.
Nor was a bit of a difficult one.
Yeah. Yeah, I think there may be a very similar patient, but I think I know which one you're talking about. But yeah, it is very difficult and it does get very, very complex. Ultimately though, I mean, the law is not black and white. There is a lot of grey areas. So obviously the biggest thing is, great, if you can look at the Mental Health Act in order to treat that person, then that's the way you should do it. But obviously your scenario where they're not, and actually a 5-2 might not have been appropriate either, to hold them there for the reason of getting an assessment.
Because I don't think the assessment would have changed. Like, he'd already been assessed several
Yeah.
times. The assessment would have been exactly the
I don't think he's ever detained, actually, if I'm thinking about the person. But yeah, it does get very, very difficult. But of course, if you do have concerns, like genuine concerns about a person's, you're not just going to let them go home and potentially, do more harm to themselves if it's, risk to life or anything like that.
But I think the decision was whether it's going to do more harm.
Actually,
go home
yeah.
calmly than loads of stress, forcing a unit of blood into it,
Yeah.
and letting it go home.
Yeah. Yeah. Did you get any legal advice or anything around it?
Well, I think because we tried to avoid sectioning it, obviously people didn't feel comfortable letting it go home, so we did the liaison team came and they're obviously busy with other stuff, so it took a few months. So.
Yeah.
I think he ended up briefly under reception 5-2, and then it got, because of the fact he'd been assessed before, and changed, he could be.
Yeah, I mean, it is difficult, and you probably get more than one person under that, in the same circumstance. But it sounds like you're familiar with that patient, and actually people know what to do now. As long as, of course, you've got safeguarding behind you and ESH legal services and things like that behind you as well. Then ultimately we're doing what's best for that patient. We have a duty of care.
From our point of view, if you not deliberately, inadvertently put someone on reception 5-2, I guess incorrectly, are you at any personal risk?
If you can justify that at the time I've put that person on a 5-2, all at the time, everything was as it should be and they met the criteria and I had my concerns and I can justify why I did it, then no, there's not going to be any fallback. It might just be as long as they meet that criteria, you can use it. A psychiatrist might then come along and say, I don't agree, in which case you can say, okay, fine. But yeah, I wouldn't worry about any fallback if you're using 5-2s, if you can justify why you've used it. Okay, so this is a scenario, again, might be familiar scenario. This is about kind of younger person, so a patient on a children's ward who had an eating disorder and they required specialist placement. So this, obviously, the placement doesn't happen overnight, so that child had to stay on the ward in the general hospital in the meantime. So the team were managing it and they were happy to do that. Obviously, in the meantime, the patient was actually, at times refusing to eat. So we have a few options here. So an eating disorder is a recognised mental disorder. So if a patient is refusing to eat, ultimately that is kind of refusing treatment. I don't know what that says, hang on. There we go. So if a patient is refusing to eat, that could suggest that they're kind of refusing their treatment, they're not consenting. So you could, if other criteria is met, you could arrange for a mental health act assessment, and they could detain that person. So now that they're detained, you can actually force that treatment on that person. Obviously, always try to obtain consent anyway, but you have the powers there available if you need them. If this was the case and you went down the sectioning route, then this person could be administered an NG tube because that's treatment for that mental disorder, because it's an eating disorder, and you could use proportionate force to administer. Obviously, this might not be something that is appropriate to do in a general children's ward. This might be something that the placement would do. So while you're waiting for that, if that person is on section, then you can maintain and prevent deterioration of that mental disorder, and you can do that. It's all considered treatment, so you can support that person whether they consent or not, because they're detained under the Act. Any of this scenario though, if a person is detained, then you will always need to obtain the authorisation for any treatment given by that person's responsible clinician. So whoever's in charge of that treatment for the mental disorder, you need to get their consent and authorisation to give that person that treatment. So again, just emphasises that unrelated physical disorders or anything that's not related to their mental health, you can't use the Act. So the fact that they're detained is irrelevant. Again, you have to use either obtain consent from the patient or use the Mental Capacity Act if it's available to you. This person, because they're a child, potentially could be under the age of 16, so in which case the Mental Capacity Act wouldn't apply. So you would have to look kind of maybe down the routes of obtaining parental responsibility consent, if that was applicable. Any questions about that one? Again, this can be a very complex situation. Nothing's as simple as it's written down, but obviously we're all there to support. And if they're detained, always try and get conversations and communications with that person's RC, so that they can potentially help with maybe treating an ailment that might be linked. So, a responsible clinician. So this is the person that is overall responsible for a patient's case. Anyone that's detained must have a responsible clinician. So this person is then in charge of all of the treatment that's given to that person related to their mental disorder. Anyone who is a responsible clinician has to be an AC, so they have to already be an approved clinician. And usually these people could be registered medical practitioners, psychologists, nurses, social workers, anybody with that extra training and accreditation. So anyone who's an approved clinician, whether they are a psychiatrist or not, they could act as somebody's RC, but generally when you get patients who are in acute hospitals, you generally have like a psychiatrist, like a liaison psychiatrist who comes and acts as that person's RC, purely because there's a specialist there. So, moving on to things you could do if you have concerns about patients' mental health. If somebody is an inpatient and they're trying to leave, I mean, you've mentioned it already, what power would be available to you, if any, if someone was trying to leave and you had concerns?
So Section 5.2, or do you think they lack capacity then to sort of goals?
Well, even if they lack capacity, you could use a 5.2. Because the Mental Health Act doesn't rely on whether a person has capacity or not. But yeah, depending on the circumstances, DOLS could be an option. So yeah, your 5.2. So obviously there is criteria for this. Obviously we don't want to use 5.2s just because we don't want someone to leave. They have to meet certain other criteria as well. But we can use this to hold a person on a ward and keep them safe. if they're trying to leave, if they are actually saying to you, I don't want to be here, I don't want to be here, they're refusing to stay, or actually they may have already left and come back again, and they may have been like a flight risk. You can use this if a doctor who's FY2 or above, or the approved clinician in charge of the patient's care, believes that the patient has a mental disorder. So actually we think you're suffering with a mental disorder, but we don't necessarily know what. You don't want to stay here. You're always trying to leave. You're constantly getting out of bed and going to the front doors. And actually, if you were to leave, you'd be a risk to yourselves or other people. So that's kind of the criteria for a 5-2. Ultimately, if we detain someone on a 5-2 or hold someone on a 5-2, we want them to be assessed because we have concerns, so we need to further look into this. So anytime you use a 5-2, a referral for an assessment to like the liaison teams needs to happen so that you can look at other options and further support. 5-2s can be used on any inpatient ward, but they can't be used on A&E or any emergency departments. That's just what the Act says. This is one of the forms. Has anyone actually written one of these? Yeah. Did it look like this when you did it? Or was it like a pink piece of paper with... These are the ones you should be using. Generally, all of the government forms are exactly the same and they can be used by any trust. But these are the new ones that were put in place probably a year ago now. But obviously, there's just some guidance here on how to complete one. 5-2s from acute trusts tend to be the most common section that gets invalidated, purely because people aren't familiar with writing the forms. So what I would recommend is read the form carefully, take your time, and just make sure that you've completed it appropriately. Because ultimately, we don't want to tell patients that they were detained unlawfully just because of an error on a form. It can add more stress to that patient. So just a few guidance here, just a few tips on it. Always make sure that you complete the full hospital address. We've had a few, really obscure addresses, not very full at all. So always get into the habit of writing the full trust and the address of the hospital. Write your name and write it clearly. And obviously if you're completing one of these and you're acting on behalf of the consultant, then you should always select the option B. You probably can't read it from there. But when you go to have a look at it, do read it, but your option is B. And always include the name of the patient. Sometimes we've had them switched around, so the patient's been at the top and the doctor's been at the bottom. Doesn't massively matter, but obviously just keep an eye out for that. And always explain why you're using the holding power. So this is where you would refer to those bits of criteria. So always explain, this person doesn't want to be here, they're trying to leave, we think they're suffering from a mental disorder, and there's a risk to themselves or other people. You're justified then. Then you have to furnish this report. So this is part of the form. Most of the Mental Health Act forms have this section. So you have to basically hand it to someone to accept it, so that everybody's aware that this person is on a 5-2 and that this is what's happened. So there's options there. You can either deliver it by hand, so you either hand it to someone that can accept it, or you can email it to them. You can do these electronically, so you don't have to print them off and handwrite them anymore. But you can still handwrite it if you prefer. And then, of course, sign and date the form. If you're ever completing one of these, you always have to let the matron or the site manager know, because they're the ones that should be accepting it. So have them come and accept it, either by email or come down to the ward or wherever you are and take it from your hands, and then they will complete part 2. And then that is the form, done and dusted, it's all complete, it's all lawful. It then gets sent to the Mental Health Act office for checking and processing. Okay? There is a checklist, so if it's the first time you're completing it and you want to be sure that you're doing it correctly, there is a checklist available. I think it's available on the ESHT intranet, but I would have to check. We've given it to everyone, but otherwise the Mental Health Act officers have one. But ultimately, just read the form, make sure that you're reading it and taking your time. So, the paperwork's out of the way. This person's on a 5-2. You have to tell the patient, or someone has to tell the patient, read them their rights, and this person must stay in the hospital for up to 72 hours. This could happen. It doesn't have to be the full 72 hours, but that's how long they could be there. They shouldn't be given any leave. They should stay where they are. Obviously, a patient shouldn't be let to go home if there's no assessment happened. However, sometimes we understand that patients need to be transferred. So if it's not urgent and there's no necessity to it, they're just being transferred to a different hospital for a different treatment or vice versa, then please wait until the assessment takes place, because 5-2s are not transferable. So as soon as that person leaves the hospital, they will no longer be subject to that 5-2. Obviously, we understand that sometimes it's needed and it's clinically necessary to get that person to another hospital, but that's fine. But just consider that 5-2s, they're not in place as soon as they leave the hospital. Treatment options. So 5-2 does not authorise treatment. You cannot use the powers of the Act to treat a person if they're on a 5-2. It is a holding power only. So if any medication is required for either a mental disorder or a physical disorder, again, always try to obtain the patient's consent, if they have capacity, of course. If they are lacking capacity, then again, you have the options available to you from the Mental Capacity Act. Obviously, you also have the common law doctrine of necessity available if it's urgently necessary to protect that patient from harm. So again, I would suggest potentially getting kind of senior members of staff to make sure that you're doing what you should be in that scenario. But yeah, just remember the 5-2, you can't use the powers of the Act to treat that person's mental disorder. So there are a few outcomes to a 5-2. Ultimately, they should always be assessed, and usually they'll be assessed by a psychiatrist. First, they will come along and they will say, yep, I think this is a mental disorder, we're going to get a further assessment. Or they will say, actually, no, I don't think there's a mental disorder, I don't think there's anything underlying here, it was just an acute crisis, and all of that's over with now. In which case they will end the 5-2 and they will complete another form to formally record that. If they do think that there's a mental disorder, then a further assessment will take place. So the full MHA assessment, involving those 3 people that I spoke about at the beginning, they will complete a full assessment. Potentially the AMP might come along at the end and say, actually, I don't agree that detention is necessary, so they will end the 5-2, again completing a form. Or it might be that actually, yeah, detention is necessary, they need to be detained in a psychiatric hospital, so we're going to complete the paperwork and we're going to transport that patient to where they need to be. Or, depending on their significant of kind of physical health needs, if they're in a hospital, general hospital already, they could be detained to that ward if they still need physical treatment. If that's ever the case, then site managers and things will need to be alerted to the fact that they're detaining someone to that ward. So, just a few questions, just 2 examples and scenarios to get you thinking about the certain circumstances in what could and couldn't be available to you. So in this particular scenario, Miss A is being assessed in the emergency department following an overdose, and there are concerns about their mental health. You have requested for a mental health liaison team to assess, and Miss A is partway through initial treatment in the emergency department and now saying she wants to leave. So you attempt to discuss with Miss A the concerns around the need for treatment and concerns for her mental health, and Miss A is refusing to engage in the conversation and just repeats that she wants to leave the hospital. So could you use a 5-2 for this patient? Would you use a 5-2 for this patient?
Does that need to be a bed for everything else pretty much straight away? Because you can't keep someone in A&E on a 5-2. So if you could do the 5-2 and put it somewhere straight away.
Technically, you've got the right idea, but you're right, you can't use 5-2s in A&E. So you wouldn't be able to hold that person on a 5-2 in A&E. With your scenario, if there was a bed available in MAU, or AMU, I don't know which way around it is anymore, then potentially you could admit them, and then you have the options of 5.2s further down the line. But I wouldn't just admit them just so that you could use a 5.2, because that would technically be kind of unlawful. But yeah, right kind of idea. Does that make sense? So yeah, can't be used in an emergency department. You do have all of the Mental Capacity Act guidelines and principles available if that person lacks capacity and they wish to leave and actually you think that they shouldn't. So you can keep them there in their best interests, if obviously there are certain circumstances in place, if you thought that that was appropriate. If a person is in A&E, they have capacity and they leave, and actually you know that they're going to go out and harm themselves or go and they might have been threatening to jump off Beachy Head or go and hurt someone, then you can contact the police, and the police should support you and go and help you, and they should go and get that person. But ultimately, if there's no risk to life, then potentially the police might say, well, no, we haven't got enough people, or something like that. But potentially you could end up, the police could go and get them and then use the 136 if they thought it was appropriate. So that could be a possibility. Yes?
So they weren't in the emergency department, they were in A, and they wanted to leave, taken on a 5.2. They had an overdose, and they weren't consenting to the antidote for the overdose. Could you give them the antidote for the overdose? You can't give them the antidote.
So they're not in A&E, they're in an inpatient unit, and they're trying to leave, so you 5.2'd them, fine. 5.2, because it's not a treatment section, you don't have the powers of the Act available to you. But what you do have is the powers like the MCA. So if you felt that person lacked capacity, potentially because of the overdose, she might have had, that might all be meaning that she lacks capacity, then the person in charge of that person's treatment could treat that person in the best interests. Does that make sense?
If that overdose, if it was like paracetamol overdose, it wasn't affecting their mental function, can you say that they lack capacity because they may have underlying mental health disease which led them to take the paracetamol overdose, which is then preventing them from weighing on whether they should have the antidote?
Part of the capacity assessment is trying to establish whether someone has an impairment or disturbance in the mind or functioning of the brain. So if that criteria is yes, they do, because of the fact that someone who's suffering from shock could come under that. So potentially if that fits, and then other bits fit, and then there's lots of processes to a capacity assessment, and then that person can weigh up information or can't weigh up information, they can't communicate to you the decision, then ultimately they would be lacking capacity. So yeah, you can use that. But if the answer is no, they don't have an impairment, then they can't lack capacity. You have to assume they have capacity. So
someone could have severe depression, which you say is an impairment, but still be able to weigh up all the information and decide whether that's...
Yeah. So they don't have to, there's 2 steps to a capacity assessment, and there's lots of questions that you need to be asking yourselves. Because someone could have, someone with a mental disorder, like you just said, could have capacity to make a decision about a specific thing, but they may lack capacity to make a decision about something else. So it just depends on the decision that needs to be made and the significance of that.
If they, with a situation where that example, they can weigh up, they've got pretty bad depression, something like that, can you use the common law doctrine if you think that they're going to die if they don't have the antidote?
Are we saying they're detained or not?
They're not detained.
They're not detained, but actually there's a risk to life.
Yeah.
I don't want to tell you that you can, because it might be that there's other things that you need to consider. But if that was the circumstance, I think you should probably get Safeguarding and Legal Services for ESHT involved and get senior support. But ultimately we're there to take care of these patients, and we're not going to just let them go and die. So potentially you would be kind of justified, and the Mental Capacity Act they have capacity, so that wouldn't be applicable anyway. But yeah, I think you're probably erring on the side of caution, but I would probably want to do something. So yeah, there's a lot of grey areas and there's no right or wrong. The law will give you the guidance, and then I guess you just have to make sure you followed all the guidance and assess as appropriate. Has that helped or not? Yeah? Okay. Okay, so the next instance then. Miss B has been admitted to the Conquest and is an inpatient for physical healthcare treatment. Staff have noticed increasing confusion resulting in erratic behaviour, which puts himself and others at risk. Tests have ruled out other causes, and there is a concern that the patient has a mental disorder. You've referred for assessment by the Mental Health Liaison Service, and Miss B is now trying to leave hospital, and there are concerns about his safety and that of others if he's allowed to leave. So what about in this scenario? Would you use a 5-2? Yeah? Yeah. I think so, because all of those bits of criteria is met here. So there's a possible mental disorder, there's risks to themselves, and this person is refusing to stay in hospital. So a 5-2 would be justified. So, yeah.
How does that work practically? Because that form needs to be, you need to fill it out and then send it off to someone and get it back. But obviously in the meantime you've got someone who wants to leave, so I'm assuming we call security. But I know that sometimes they're reluctant to do anything until they see the actual section paperwork.
So I would recommend you get the paperwork done like as soon as you can, but it's not a case of, oh, hang on patient, you're not going to be detained until I've done this paperwork, because they're not going to wait for you, are they?
Yeah.
So what I would do is I would use kind of the words of a 5-2 and say, like, you are detained. I'm detaining you under a 5-2 because of this, this and this, and then get the paperwork done as soon as possible. Obviously, if they're trying to leave in that instance, then security should be doing all they can to support you because you've done that. But I do know sometimes security can be a bit of a standoffish if someone's not detained or anything like that.
But they aren't actually able to physically restrain anyone without a section 5-2 completed. As in, the security can't, if the patient's walking towards the door,
Yeah.
they can't block the door, they can't hold on to the patient.
Well, there's proportionate force involved. So if it's a case of the security could stand in front of the door,
Yeah.
then they might do that.
That's illegal detention. You know,
Yeah, it's again about thinking about keeping these people safe. Obviously, some wards don't actually have like locked doors or anything like that, and they have push buttons and things. So it could be a case of, you know, if that person is in the hospital and then gets to A&E, then you know you let them walk as far as the doors, and then you have to kind of do what you can to bring them back proportionately. Because if someone was going to walk out in front of a bus, you're not just going to let them. You're going to, like, you know, do what you can proportionately to keep them safe. But yeah, there is a grey area, and obviously there's lots of laws and worries that people might have about them being, you know, accountable for something. But as long as you can justify why you've done what you've done and the 5-2 paperwork's in place, then usually we're okay. Okay, so these next couple of information, I realise we've gone a little bit over. This next couple of slides is just information for you so that you're aware in case it comes up. So section 17, leave. This could come up in certain hospitals, patients who, they might be in Woodlands, for instance, and they might need treatment or a test or something over in the Conquest. So the responsible clinician for that patient will have authorised that person to come over here under this section. So this is basically, this person can leave the hospital that they're detained in for a certain period of time for this reason, and I'm authorising this. So you may see one of these, and if there is ever a patient that comes over here or goes over anywhere else, then they should come with copies of this paperwork. So do have a look at it if you do see one, because that will explain, you know, the patient might have conditions to abide by while they're over here. It should state how long they can be over here for and things like that. It'll also have contact details of who to call if there's an issue and things like that. So do have a look if you ever see one. So AWOLs, Section 18 can be used for those patients that go AWOL. This can be applied for general hospitals as well, because we get patients detained over here. So if a patient under Section 2 walks out, leaves the hospital, goes AWOL without, no one knows or no one allowed them to leave, then you can bring them back. There is powers under this section to bring them back to the hospital that they're detained to. Obviously, there's lots of different scenarios and circumstances that could apply, considerations that you might have to take into account, such as the expiry of their section. So if any of that applies, or you think that you need to bring someone back to the hospital, then I would contact the liaison teams for extra support, or the local Mental Health Act office, who can tell you what your legal positions might be around this. Section 23, so this is discharge of a section. So if someone is detained to your hospital, a lot of the time, if someone's medically fit for discharge and you need the bed, then sometimes that person's RC will come along and review the patient to say, okay, this person doesn't meet the criteria for detention anymore either, so I'm going to discharge their section and they can go home. Or they might say they meet the criteria for detention still, but there's no beds available, so they're going to have to stay here until I can organise a bed in a psychiatric unit. So keep an eye out for these sections. Section 23 is your discharge. So if you've got one of these and a person or a responsible clinician has come along and said, I've discharged the section under Section 23, then they're no longer subject to the Mental Health Act. So you can discharge them or treat them as you see appropriate. That's what one of the forms looks like. That's the paper form. I'd like to think that if anyone was discharged, the responsible clinician would leave you a copy so that you have it for the records as well. But we do have them electronically and on our systems now, so they're like an embedded form. So you may not get one. But always just keep an eye out for this one. Site managers and matrons of ESHT have a responsibility to be aware of detentions, Mental Health Act usage around their hospital. So they have to accept paperwork, such as the 5.2. They will accept detention paperwork that the doctors in the AMP complete. They should come and accept that paperwork. They will arrange transfers or help to coordinate transfers of patients in and out of ESHT. They are responsible for advising patients of their rights under the Act. They're also responsible for recording them, and they act as like a communication between liaison and the Mental Health Act office. So it's really important that if you do ever use 5.2s or anything, or if you've got someone with mental health concerns, then do alert site managers or matrons to those concerns or that use of a 5.2. This is just a glossary of the terms that might crop up under the Mental Health Act. If you see one, you don't know what it means, then it's here for your reference. Some of them you might never come across. Some of them are quite familiar for quite a lot of people. Do you have any questions? No? Okay. Well, I hope that's helped a little bit. If you do ever have any questions, then I've included the details of the relevant local Mental Health Act office. Lucy is the kind of line manager of that office, so she's around as well. And then you've got myself and Jolene, who are the trainers. So if you do ever have any questions or anything, then there's lots of people to contact if you wanted to talk anything through. Okay? Cool. If that's everything, then I will let you go. Thank you for your time.